Can't make you. That Elizabeth So is always the first one.
Right.
Tried talking to her once. She never answered me. Find the bio for our speaker.
While you're doing that, I'll let some people in.
Okay.
You got it. Diesel catapang.
Yeah,
That's interesting.
He's from probably the Philippines.
Yeah.
There was 103 on last week.
Yeah, I know.
Total. Were some of them Jay's crew? Is that?
I think so. And maybe even Hunter.
Yeah, they're like joined at the hip.
Yeah, they are.
So
So I noticed this is new.
what's that?
Your everyday adaptogen.
Yeah, you get. We always got good new stuff. Do you want to try it? Take
Or do you
it.
think it's for energy?
Yeah,
I kind of figured.
stress. Tension and toxins.
Well, guys, no joke, that's for sure.
Mm-hmm.
They're a heck of a company. I suppose I could try it, put it in my water.
Mm-hmm.
Right now I do the electropure hydration for 30 ounces of water. They say I don't know, 10 to 12 ounces. It's like, no way. That's not economically feasible.
What?
I mean, this thing holds, what is it, 40 ounces? And I usually put 30 ounces in there and I do one of your little electropure hydration packets.
You do the whole packet? I tried it. It's brutal.
Not bad. But that's with 30 ounces of water.
Mm-hmm. Yeah, last week, this time I was on a boat cruise in the canals in
Right.
Fort Lauderdale. It was pretty nice.
Yeah.
So,
I've thought about a cruise myself.
cruising for a bruising.
Yeah. Well, just to even get away
Yeah, so
from dad.
this was
Look at that. Isn't that something?
these are the guy who was saying these are one of these houses is Tiger Woods. Somebody else,
She's having a blast.
Have our speaker on.
Who's the speaker?
Jacquelyn Sammons. Yeah, got her from Halassa. Yeah.
phone. Well, let me go see if I can find my phone.
Yeah.
Hey, Dr. Bell.
Hey Ken, how are you? Sorry,
Good.
sorry I missed you last week. You were over at A4M, right?
I was.
Yeah,
That was there was some good information shared. I can send you the slide decks for the 2 days if you want.
sure, that'd be great.
Okay.
Yeah, we had some
I
good stuff.
know.
Yeah, we had
Go
some
ahead.
good stuff too.
Yeah, you were at AMMG, right?
Right. Yeah, we're like Avis.
There's
I don't know why.
Doria's probably gonna reach out to you and see if we could get your help with this marketing program we're bringing the doctors. We want you to take a look at it and
Sure.
see if you like what we're pitching.
Okay.
Cool.
Sure. So
I talked to Andy over the weekend.
yeah, I think I don't know what to
What
think.
are we going to do about I mean, he wants to have the conference. There's some that are still going to come out there,
I'm
but
not.
it's,
I couldn't go. I wasn't going to be able to go anyway. But you know,
yeah,
I've run these things. I mean, you just don't. Okay, we're going to have a conference in 3 weeks. You know?
it, it doesn't work well.
No, it doesn't. So
Okay. Well,
we don't have our speaker yet. So
I told him I would give a talk, so we'll see if stuff materializes clearly. Other than that, how are you?
yeah, good. Bumping along, doing our thing. So where are you
I'm in
at?
my
You
I'm
need
in my backyard dealing with a broken branch on my peach tree. It produces so many peaches. I thin it out, and it still is just overwhelming. The fruit's fabulous.
yeah. Well, we don't get that in Reno. So I got
Uh,
Send some
my,
over,
my
Ken.
backyard. My backyard has moles ripping up the yard, and I can't get rid of them.
well, the peaches.
We'll take the extras, Ken. Don't worry.
Yeah.
Don't throw it
Well,
away.
you'll be battling my 6 kids and 6 grandkids.
Yeah, I think we're good.
All right.
We'll have more of that here, hopefully.
Try to make Dr. Nario. You're the co-host, okay?
All right.
And I got Joel.
Well, I am going to go silent so I can finish this job before it gets too dark and cold.
Well, be careful.
I'm listening.
Don't be tripping or falling.
Amen to that.
Okay, I don't know where our speaker's not on yet, so hope she's not lost.
I actually stopped Dad from.
Oh, here she's in. She's in, Dr. Bell.
There we go.
All right. I was going to panic and have to do it myself. She sent me the slides, so and
Hey, it's hormones anyway, so you know everything about hormones.
I don't know everything. I make it up as I go along. You figured that out by now, right?
Yeah, you know everything by making it up as you go along. Maybe that's a better sentence.
Yeah. So last week I heard there was some fireworks. Uh,
Fireworks,
we had
an understatement.
yeah, we had 103 on. I don't know if
Yeah, that was a good crowd.
Jay brought that. No, I had to count. It was 103, which was that could be our record. That was more than when I think we had Dr. McCullough on.
Right. It was.
Yeah, yeah. So you see how hot peptides are.
Yeah.
They haven't given the slides yet, so I don't know if they're going to share it.
Oh no, he told me he wasn't going to, although he kept promising it on the show. I actually listened to the whole thing. No, so just to let you know, um, the videos on so everybody was on last week with Jay Campbell. The video is on our
Vimeo.
YouTube channel and also aosrd.org/webinars. Jay's decided not to release the slides to us for whatever reason. I don't know why. So you're going to have to screenshot the what you want. I mean, there were a bunch of summary slides. I think that would probably do. It's not up to me. Sorry.
No, because I think they were still trying to edit that. So if you listen, he's asking Hunter, like, what is this all about? So it seems like it's not the final product.
Yeah. Well.
So Hunter kind of is the mastermind of
Yeah,
the whole
I kind of got that impression. So
Well, and I think they're trying to stay out of trouble also.
he's always in trouble. What's this?
Yeah.
I think trouble he invites trouble in, isn't he? That's his middle name. So anyway, Jay's all right. I like him. My one real beef is that we all have to watch our P's and Q's because there's bad people out there want to decapitate us. He's got no degree in anything. He can say whatever he wants and nobody right. And he's I got an email. I get their email. I got an email today. Hunter's recommending Jardiance as an anti-aging remedy along with Retratitude or whatever you
Ratatouille.
Yeah, they call it ratatouille and metformin. Those three.
Yeah.
That's a metabolic stack for longevity. That's kind of crossing skirting a line of medical doctordom. I don't know. Seems to be,
unless they tried it on themselves.
Well, first of all, where did they get the stuff? I mean, metformin and Jardiance are,
India Mart, right?
Huh? They get it from India Mart.
India Mart. Plus tariffs now.
We get back in the bad old days. I got 1,000 12 milligram ivermectin pills. At least that's what they claimed they were for $155 from India.
And you just paid for powder.
No, it was the pill. There were pills, but they were white. They weren't stamped or marked anything. It came in boxes that said ivermectin.
So it worked. It really made you believe that you got ivermectin.
You got it. It's right there.
Where's it at?
Right behind them.
Here. I don't know if you can see it. Here it is.
Probably expired by now.
Oh, you think these have an expiration date?
That too. It's not there, huh?
You're dreaming. So, okay, our guest is here. You want to save did you do the tip of the week last week, Dr. Nario? Or
no, I was hosting, so I was busy. So okay. I have my tip of the week.
It does say January 2025 as an expiration date here. This is from the Lancer Therapeutics in
it's written on pencil, right?
Yeah. Mm-hmm. Yeah. See, here. See, it says ivermectin right there. 12 milligrams.
Yep, that's the real deal. I can smell it from here. Oh, Mary Elaine wanted to give a shout out. National Nurses Week, May 6th to 12th.
There we go. Okay. National Nurses Week. Okay.
Hoorah.
Definitely.
Okay.
We can't do without the nurses.
All right, so you're getting a sense of the group here, Dr. Sammons. I know you. I think you were on with Dr. Halasso, right? You're muted.
I
Yeah,
am.
yeah.
There we
Oh,
go.
I
right.
hope you're getting a sense of the group here. You know, we're very serious about all this.
Yeah, it sounds like it. No, this is like right up my alley. It's super tight laced,
I like. I feel
absolutely.
liking us to a MASH unit,
I
right?
like
This
it.
is
I think that's the most fun. That was the best show ever.
Yeah.
We
So
need more shows like that out there for
like
sure.
liking us to that, when we have to be serious, we're serious, but the rest of the time, you know, we at least give Dr. Burgess a hard time just just because he takes it so well. So
I always tell my husband, if I don't give you a hard time, who's going to? And what fun would that be? So
okay. So thank you, everybody. I guess we can get started now. We can do yours after. So, just to let you know, Dr. Nario is taking Andrew Weil's integrative medicine courses at the University of Arizona. So,
oh, wonderful.
every week we've been on every week here since 2020 October. Dr. Nario gives us the tip of the week, what he learned, so the rest of us don't have to go spend $35,000 in 2 years.
I appreciate that.
So we learned
yeah,
we
hopefully,
learned bicycle seats. What else did we learn?
yeah, prostate. Take care of your prostate. Don't be riding on bikes.
Yeah. Okay. So we'll get it afterwards. Okay. So we're gonna let
Yes.
Sammons do her thing because she's probably getting bored listening to this nonsense. So
Oh, I'm having a great time.
so
Let's see. I'm going to
Dr.
see if I can share.
So I'm going to do a little introduction. Okay. So
Oh,
Dr.
super.
Dr. Jacquelyn Sammons is a board certified obstetrician and gynecologist. She practices in Orange County, California for the past 10 years. She serves patients at the Transformation Health and Wellness Center in Anaheim. She was educated in Southern California. She completed an undergraduate degree at California State University, Fullerton, and she earned a DO degree at Western University of Health Sciences in Pomona, California. She interned at University of California, Los Angeles, and she finished her residency training at University of California, San Diego before returning to Orange County. You need to get out of California, right? It'll give you a whole different perspective on things.
So we have property in Arizona and I just love it in Arizona, but boy, it's hot in August and September. Holy mackerel.
Try Iowa or something.
Then there's snow. I'm not a big fan of that either. I'm too spoiled here in Southern California.
I went
But the taxes suck. The political environment sucks, but it's all right.
As a provider, Dr. Jacquelyn brings an outside the box problem solving approach to health and wellness, along with a unique mindset. She views the human body as a dynamic unit. Patients' health needs are not cookie cutter, one size fits all. She aims to provide each of her patients with a personalized plan of integrative care. She brings a fresh, refreshing perspective to optimizing health outcomes for each individual who walks through her door. Her extensive training enables her to hone in on root causes of ailments to find appropriate remedies. We could go on and on and on here. But so I'm going to let you finish the introduction yourself. So everybody, please welcome Dr. Jacquelyn Sammons, and we're honored to have you here.
Oh, thank you so much. That was a really warm, gosh, it makes it sound like I know what I'm talking about. Good heavens. So I've been in the integrative space for about 6 years.
Yep.
Let me get unmuted.
Am
I unmuted again?
Yeah, no, yeah, you're fine. That was me. I went to let somebody in and they got in. I messed it up. Go ahead.
Yeah, that's okay. It's like we've had enough out of you. Thank you. That's all right. Dr. Clearfield reached out to me after I gave a talk to American Academy of Stem Cell Physicians on their webinar series, and then with Dr. Falasa, and kind of wanted me to challenge myself actually in sort of discussing aromatization and aromatase blocking in men when we're treating men with hormone replacement therapy. So it's a little outside of my whole comfort zone. I've been a little newer to treating men over the last 6 years. And as I'm finding is true with men is also what's true with women, as far as a lot of what we do in practice has to do with urban legend, myths that have been passed down that we think we're supposed to do it this way because somebody said that's a problem, and there's some kind of little Google search thing over here, but really the evidence is a little bit sparse. Unfortunately, I'm hoping we're going to get some more evidence eventually, but hopefully we're able to combine some of this here today and kind of get people a better perspective on it. Here's our objectives page, which always just helps me to keep focused. We'll see how much I stick to this, but kind of an understanding of what is the aromatization, why it's important, common practice of aromatase inhibitors that we use, and then best practice. And once I kind of dove into the literature a bit, it turns out that sort of what I was taught urban legend wise maybe isn't actually how I should be managing patients. So thank you, Dr. Clearfield, because now I'm able to kind of modify my own practice with what I've learned just in the last, several weeks. So this is interesting. Okay, so I wasn't sure everybody else's background with this group as far as management of men and testosterone deficiency and how to diagnose it. So I don't mean to be condescending, but I like to put my presentations together for completeness sake. Because if you were to come at me and tell me about nephron health and pushing sodium and potassium, like I have no idea. I don't remember. So I kind of like to put these things in there. So in the common medical practice, we're going to see, or the Western conventional medical practice, we're going to see that testosterone deficiency is defined as a total testosterone of less than 30. I really pay more attention to the clinical presentation of my men. If you're coming to me and you're having chronic fatigue, you can't lose weight, you don't have any motivation, you can't get off the couch, you can't get your wife's honey-do list done, you're not getting gains at the gym, nor even any motivation to get to the gym or do anything active, and you have a testosterone of 500, you're still low. So it's more about clinical presentation in addition to those objective lab findings, but I really like the benefit of those lab findings as well. I think an optimal testosterone is anywhere from 700 to 1100. Really, when you're getting beyond this to this super physiologic level, I don't think there's added benefit. And that's when we start to see that patients have more of the aromatizing side effects of converting that testosterone to estradiol. And again, I like to restore physiologic balance to my patients, not necessarily super physiologic levels. I think that's when we start screwing patients up and having these iatrogenic issues. When we're kind of push, these ranges are kind of put there by God or Mother Nature, however you want to view it, for a reason. And so more is not always better. So when I have my patients coming in, they're like, I feel great on 2000. I'm like, yep, but you got a big old pot belly. And now we're back to not being able to get off the couch, and you're super aggressive and emotional. So not great. The literature was kind of mixed when I reviewed. It was anywhere from 2.1% of US men to 40% of US men. I really think this quote of 2.1% is grossly underestimating where our men are. I would say, particularly in my practice, it's probably pushing 30 to 40% of my men have a testosterone deficiency if they're not managing it actively. And again, we can manage this multiple ways. Doesn't necessarily need to be with testosterone replacement therapy, and we'll get into that a bit. They state that it worsens with age, but I don't know that that's true historically. I think historically we still maintained testosterone levels, but also historically we died at 40 from farming accidents and communicable diseases. So it does seem to worsen a bit with age, just as everything kind of is more and more impaired as far as functionality. Symptoms of testosterone deficiency can just include reduced libido, erectile dysfunction, low energy, sorry about the typo, fatigue. Fatigue is a huge symptom of my gentlemen, poor concentration, depressed mood, irritability, mood swings, just emotionality. They're super tearful. They're crying at Kodak commercials. They feel like their wives. And I say it kind of tongue in cheek, but also like as a perimenopausal woman, I don't like myself either. So if I were a gentleman coming to the table with the ups and the downs and the all over the place without being like Mr. Steady Eddie, yeah, it would be hugely disconcerting. Increased body fat, particularly in the abdomen, decreased muscle mass, and a loss of bone density. So I think it's really important. We tend to focus on those objective numbers. We get our labs done and we're all excited because we've made this amazing diagnosis of decreased testosterone or testosterone deficiency. but we haven't thought further. Why is this person testosterone deficient? Why aren't they making it? Is it a hypothalamic dysfunction, a primary pituitary dysfunction? Was there testicular trauma? Did he have an orchiectomy from testicular cancer in his mid-20s? Like, what else is going on? Traumatic brain injury can be a major source. Viral infections like the mumps, Klinefelters, radiation, chemo, other medications, undescended testes. So again, some of these are going to present when you're much younger, but a lot of those can also be things that we acquire over time. Obviously not Klinefelters, but we can get a pituitary dysfunction, or we can all of a sudden sustain a brain trauma that will affect our hormones. Other causes, diabetes, anemia, or hemochromatosis. So it seems that hemochromatosis can actually lead to a lot of impairment system-wide, organism-wide, I should say. So things like brain fog and fatigue and liver congestion or elevated LFTs, difficulty breathing, et cetera. And I think it's because there's so much of these blood cells running around that it's just clogging up the works. The iron that these men have is really affecting that capillary flow. So we get decreased blood flow to the pituitary, the hypothalamus, and the testes. Chronic hypoxia, obstructive sleep apnea, particularly smoking, excessive alcohol consumption, chronic hypertension, obesity, consumption of trans fats, but just also ultra processed foods. I think RFK Juniors and as well as the Casey Means and the brother Care. So those individuals are really bringing to light how much of these ultra processed agents that we're putting in our food here in the United States is affecting our health. So I think that's coming to the surface much more. It's not so much of a rabbit hole conspiracy theory any longer. Now the bigger question is, what do we do about it, right? Just aging in general. We don't do things as well as we mature. So that's where we come in as the types of providers that we are, is to try to help mitigate some of those aging elements so that we can sustain a better steady state longer rather than be in a steady decline. And psychological stressors. Certainly if we're having like cortisol abnormalities, massive psychological stressors, we hate our job, we just got laid off, the wife's divorcing me, all of these kind of things, my kid's on drugs, these sorts of elements can affect that cortisol level. And if we have too much cortisol, we are not going to effectively or allocate some of that energy production to our sex hormones. If we're not safe to be reproducing because we're in survival mode, then our body's not going to allocate energy to that. So important to keep in mind. Okay, a big topic in discussions is these what are called endocrine disruptors. And I think this is one of the primary issues. Why are almost half of our gentlemen in the United States suffering with testosterone deficiency? It's not all that we're just maturing. Of course, we are an aging population. Birth rates are down. So as a whole population, we're sort of towards that later part of our timeline. But I think there's a lot of environmental factors that are really contributing, not just to men, but also to women, that we're seeing estrogen dominance in women, polycystic ovarian syndrome, insulin resistance. I mean, that's been my bread and butter for the last 20 years. But as we then look to our male counterparts, this has really affected them as well. So there's sort of grumpy, dumpy, heavier set, like squishy tissue, right? So it's not just that it's a gentleman who's maybe not working out as much, like marshmallowy tissue. And you can really tell if you ever start IVs, how they're just sort of, I don't know, for a better lack of word, just squishy. And so it's really just inflamed, poor integrity of that tissue. And I think it comes a lot from these endocrine disruptors. So they have anti-androgenic effects and estrogenic effects. So it's not that just we're blocking testosterone or formation thereof, but also that we're converting more to estrogen. It interferes with the hormone production and release, transport, metabolism, binding, and elimination. So it's like every single element of this pathway. Really, with hormones, what we want to do is consume our cholesterol. We take that cholesterol ring, reform DHEA, and then that ring is going to convert through various enzymatic processes to become our pregnenolone, progesterone, estradiol, estrone, estriol, testosterone, DHT. So this is happening through those other enzymes. So if we're blocking metabolism enzymes, then after we use it, we're supposed to methylate it, and then we get rid of it through liver metabolism, some through kidney metabolism as well. And so if we're not doing that, or we're increasing our resorption of those kind of used recycled hormones, they typically are more highly inflammatory. So examples of what endocrine disruptors are is, like, again, herbicides, pesticides, plastics, and food packaging. So just, okay, we're going to go get organic chicken, but it's packaged in plastic. How long has it been sitting in that plastic? How much plastic did it encounter in the machinery at the factory that was pulling the bones off of it, and so forth. Various pharmaceuticals, dietary components, BPAs, again, plastics, containers, linings of various things, just linings of our plastic bags that we bring our groceries home in. Even our clothing has plastic. I like my nice stretchy clothes because they're super comfortable, but it has plastics in it. So that's going to affect us as well. Phthalates, so industrial compounds such as flooring, walls, mats, these kind of things. Personal care products. This is something, again, much more concerning for women, primarily or historically, but now I think a lot of men are getting into more of a skincare regimen, and I need to use this type of shampoo, and my wife likes me to use this cologne, and I'm using deodorant, and so on. So even though it might be relatively small in comparison to our female counterparts, men are still getting those chemical exposures. And even just cuddling up against your wife, if she's put hand cream and lotion all over her body at night and you cuddle up next to her, you're getting that skin to skin exposure. You're getting some of that absorption as well. And then PCBs, like paints, oils, building materials. So our industrial gentlemen who are out there on job sites and construction, or painters, et cetera, they're getting that exposure as well. So how do we evaluate these patients? Again, I put this in because I know we're supposed to be talking about aromatase blocking, but I really feel super strongly about it getting objective data. We've got to find out where these patients lie as a baseline and then follow them along as we have intervention to ensure that what we're doing is working. So we have to have this, this baseline. So FSH, LH, total free testosterone, DHEAS, estradiol, progesterone. I like getting a prolactin because if you have, for example, a high FSH, LH, a high testosterone, do you have a primary testicular issue that you're having an overproduction of testosterone? Like, what's going on? So you can have some of these other elements being elevated or depressed. And then prolactin can also help to discern, do you have a primary pituitary tumor that's causing these things? Like, where is the nut underneath the shell game, right? So is it primary pituitary, hypothalamic? Is it testicular, or other? Right? Is it undiagnosed diabetes? Sometimes they'll come in and just like really, again, dumpy, grumpy, lack motivation. I don't feel good. I have to nap every time I eat. It's miserable. And their A1C is 7. So that would be an important opportunity to intervene and correct that pathway. I like, when I check thyroid, I check TSH, free T4, and free T3. That's going to give you the best kind of assessment of what that whole thyroid axis looks like. A pituitary thyroid axis. Vitamin D insufficiency is a huge player in immune function, sex hormone function, bone mineralization, etc. It's got an enormous role in our bodies. Super important hormone. Don't forget our vitamin D. I also like checking a fasting insulin, again, glucose, A1C, AST, and ALT. This is going to give you a good indicator of how well your liver is clearing. And if you've got some non-alcoholic fatty liver disease, if you're not clearing appropriately, you are not going to do well on testosterone therapy. Ask me how I know. I've had so many patients that they're like, just stop, just, I know I'm going to do well on it. My buddy did really well at the gym. Give me testosterone. Okay, fine. And I do. Then they get their labs, then it comes back and their LFTs are elevated. And when they come back for their follow-up lab review, they're like, yeah, I was feeling good for a month, but now I'm just really like heavy and I'm back to where I started, and so on. And it's because they're now aromatizing. They're not clearing those hormones appropriately. So it's giving that testosterone enough time to hang around so that it's now getting estrogenized. So we want to make sure they've got good liver clearance before commencing therapy. I like checking MTHFR and homocysteine. The incidence of MTHFR mutations in the US is anywhere from 10 to 50%. And so a lot of us have an MTHFR mutation that is going to affect methylation. And if you recall what I just said, the methylation is what is responsible for processing those hormones and getting them kicked out of our system. It's also responsible for portions of that kind of twisting and curving, or the aromatization, enzymatic changes of these cholesterol rings to form the different sex hormones. So really important. And then that homocysteine should be less than 10. And that's telling me that you're methylating and getting rid of things appropriately. If we've got a homocysteine of like 12, 15, I think my highest I saw was like 26. These folks are going to really have a hard time clearing whatever you do, right? So we want to make sure to correct that first before commencing therapy. Okay. So what are some management strategies? Again, I like to use testosterone therapy sort of as an ultimate approach, right? So we want to fix their diabetes first. We want to make sure that they're working out first, make sure that they're eating fewer ultra-processed foods, that they've reduced their alcohol intake, we have better sleep hygiene. Fix your sleep apnea. I can give you all the testosterone in the world. If you are still snoring and choking, it's essentially like your body's being strangled every single night. Your body is not going to do well with just testosterone. So now you're going to be grouchy, you're going to be super therapeutic, and you're still not going to feel the best benefits of that testosterone. So we want to treat all of those underlying diseases first. Remove or diminish any of these endocrine disruptors. Again, I'm not giving up my stretchy clothes. It's just not happening. I love my sports bras way too much. I'm not giving up the little amount of makeup that I use. So to a degree, right? If you can start cooking in glass containers, using cast iron skillets, minimize plastic bag use, put your foods, if they come in plastic packaging, putting them right into glass containers right away. Just small steps that you can do little by little to make those habits without getting completely overwhelmed with our culture as it stands right now. Introducing things that can also just naturally help with testosterone production. One is lifting heavy, as I mentioned up here, more clean animal protein consumption, more healthy fats. Maca root can be helpful, nuts, ashwagandha, ginger, and fenugreek. So these are some herbal things, or again, nuts, not herbal, but nonetheless, these are some dietary things that you can implement as a gentleman to help build those levels intrinsically. I have found that my patients who implement this, it might correct if you're like at 550 and you're feeling a little sluggish and lacking motivation. You start lifting heavy, getting that part of your habit, and putting some ginger, fenugreek, and maca into your, tea or protein shake every morning. You're going to get your levels up there. But if you're looking at a gentleman who's got a testosterone level of 250, you're going to have to be eating a lot of ginger to get you up to therapeutic physiologic levels of testosterone. So, it's not that you're wasting your time necessarily. I just think that these natural supplements are not going to be the whole answer. Again, just an opportunity, you want to correct their magnesium, zinc, and vitamin D. DHEA, like I mentioned, he's sort of a little brother to testosterone is the way that I like to look at it. And sometimes you can get a bit of correction with just giving DHEA, and some of that will convert over to become testosterone. Again, I've not seen such an overwhelming level of conversion that we go from super poor levels of testosterone to way fantastic motivational levels of testosterone, but it can help. And with the benefits of DHEA otherwise as an anti-inflammatory, brain protection for cognitive health, it's got other benefits as well. So you want to correct DHEA anyway. And then there are a variety of peptides that are coming to light. There's like Aromatize. Hold on, one of my colleagues just sent me this guy. He's like, you got to try this. And I was like, fantastic. I don't know anything about it. The Aromacin is what he's using. There's also something called Kispeptin, which helps at the hypothalamic level. There's a gonadotropin, peptides that kind of help build those, again, from a hypothalamic standpoint to build that pituitary signaling. And so from there, you'll get your FSH and LH, which will build your testosterone theoretically. So I think peptides for a lot of us, for me in particular, are very new. So it's not that I think there's not a value to them. I think it's still quite a bit of wild, wild west, if you will, as far as how much do we dose, how long of a break, do you put it in the morning or the evening? So there's a lot of logistics about it that I think are still somewhat mysterious, and there's not so many of those protocols. for example, if I tell you like, hey, I gave this patient a Z-Pak, you know exactly how to write for a Z-Pak, you know how it's dosed. Everybody's same. No matter if you're in Maryland, California, wherever you're from, it's going to be the same dosing because there's a defined protocol and an understanding in the community how we prescribe that. But with peptides, I think there's still just a lot of variance. And it's not that any of it's wrong or that it's hogwash. I think that it's just, I'm still not completely well versed in how a lot of these things will benefit. I have a couple of patients who are on kisspeptin because they wanted the benefits of testosterone elevation, but also wanted to preserve their fertility. So with testosterone replacement therapy, you'll often suppress sperm production, and they're looking at making the babies. One gentleman just got married a month ago. So very exciting stuff. So we want to preserve that. So kisspeptin might be a better strategy for him than to use testosterone specifically. All right. So testosterone therapy. I think the vast majority of us have sort of focused on the injectable version of testosterone. I think that's what's traditionally been used. It's been used in gyms and, you know, all of these weight building, body lifting centers for decades. But this is where you can have a higher likelihood of overdosing your patients and getting those super physiologic levels that are not necessarily advantageous. I think they're advantageous when you're 25, Arnold Schwarzenegger from the 80s, and you want to be super bulked and ripped and like, yes, and have that aggression and they're throwing weights around. Like, that's great. But most of our 56-year-old gentlemen are not looking for that, at least not in my practice. They just want to feel healthy. They want to feel whole. They want to feel strong, be able to protect their families, be motivated again to do that honey-do list. I appreciate so much. So they're looking at it from that perspective. Most of my gentlemen kind of shy away from the gels or the creams. They're very concerned about getting it onto their kiddos, their wife. I was going to say wives, but hopefully they just have one wife. We're a lot. You don't want to have wives. Just personal recommendation. But they kind of avoid the gels and the creams. If they are going to use a gel or a cream, I usually suggest use it in the morning and then put your undershirt over the gel or the cream. Like put it on your upper chest, then put your shirt, then wear your, you know, work clothes, suit, whatever it is. And don't have wife, you know, snuggle up next to you on the pillow right after applying it. So that way it's gotten full absorption before you go off and you take your shower at night and go into bed. Troches are a fantastic form of administration. So this will be a sublingual, kind of like a gummy that absorbs under the tongue. Beautiful. These are absorbed beautifully for patients. I easily get their physiologic levels restored. I can get to super physiologic, but we have to try really hard. And then they're easy to divide up. You can cut them in half. You can cut them into quarters. You can change the dosing. These are done through a compounding pharmacy, so I'm not having to mess with mixing it up and formulating it. I oftentimes will mix it with 25 milligrams of DHEA. So I'll do about 25 to 50 milligrams of testosterone with 50 milligrams of, or excuse me, 25 milligrams of DHEA. So they're getting both of these in at the same time with one tool, one prescription, one thing they have to remember to refill. And I think it works very, very nicely. With the injections, it's just very easy to get super physiologic. You're getting really hypertherapeutic doses, and then you're getting symptoms, and you'll get this peak trough phenomenon where they're super great, tons of energy for those first 3-4 days, and then they start crashing down. Okay, fine. So let's divide the dosing into 2 doses throughout the week. So we're doing Monday, Thursday dosing, and they've got holes and pokes all over them. They're getting little depot balls in their buttock or in their deltoid. So it's just, there's better ways to do it. So it's not that I don't have my gentlemen on injectable. I do. I would say it's probably 40% of my men are on injections, and the rest are mostly on troches. Pellet therapy, I don't do particularly. I've had a lot of patients with pellet therapy out there in the woods. If they're happy on it, I'm fine with still managing them for their other health issues. I just think, again, we get this really, really high peak. You know, they're on a big high, and then they start to trough out at that 2.5 to 3 month mark before they get their next pellet. It's a procedure. So you're having to cut the tissue. There's a potential for abscess, infection, site reactions, etc. And then if you are super therapeutic or having a bad reaction, you can't take it out. So it can get really difficult for patients to navigate. But for those who are happy, stay on it. Leave them alone. It's fine. So what are the side effects of testosterone therapy? Irritability, hair loss, again, starting bar fights, maybe hair growth elsewhere on their body. So we're kind of familiar with some of these. What I usually recommend for follow-up after commencing therapy is at 1 month, have them check in. So even if we're not getting lab levels at this point, I like to see how they're feeling. Are they noticing a benefit? Is their sleep affected? Are they feeling more aggressive? Are they fighting with their wife or their teenage kids more? Are they having any sight reactions? Do they hate the flavor of the troche? So there's a lot of things you can check in here and just touch base, make eye contact, make sure your patient's doing what you asked them to do. Sometimes patients come in and they're like, yeah, I know you put a prescription in, but I didn't pick it up, or I was traveling for work and I forgot it. Okay, so let's reiterate why you're going to be on this therapy. Let's talk about the benefits again. Let's get you started. So it's that ability to refocus as well. And then usually at the 3-month mark, I'll have patients recheck labs and make sure what we're doing is working. Okay, so here is that reaction. You can sort of see here how how chemically similar estradiol and testosterone are. Again, we're starting with this baseline cholesterol ring, and we're converting this double bonded oxygen to an ethyl group, and so on. So there's like these couple of little changes, just this methyl group being taken off. We don't see that on the estradiol. So that's what aromatase does, and it does it through the cytochrome P450 pathway in the liver. That's why you need to make sure that your liver is working, is so that we can activate that appropriately and have good response and good clearance. Sorry, guys, I gave a menopause seminar for 16 hours over the weekend, and my voice is still recovering, so I'm drinking my tea over here. Okay, so what are the signs of aromatization? Just basically having too much serum estradiol. And I think there's, again, this urban legend out there that this is happening to all our men who are on testosterone therapy. And it's just really not the case. So let's go through it. All right. So we get fatigue, a lack of motivation, abdominal adiposity, mood swings, tearfulness. That emotionality really throws my gentlemen for a loop. They are not happy when they're sitting there in the kitchen just crying and they're like, I have a beautiful wife, I have a beautiful family, my kid's passing algebra, like I have nothing to be crying about, and I'm just a damn mess. And oftentimes this is something they cannot share with their peers. Like they're not going to tell their buddy at the gym that they're crying at the kitchen table. They're not saying that. My gentleman in the room here on the webinar, sometimes your men are not going to share it with you either because they're going to feel very vulnerable. So I think normalizing asking that question or potentially having like an intake form or a little questionnaire that they can fill out, or have your medical assistant ask. Oftentimes our medical assistants are women, so they may feel more comfortable. Statistics show that men feel more comfortable sometimes discussing this with women than discussing it with male counterparts. Just to keep in mind, if you're not hearing this from patients, they are having it, they may not tell you. Poor concentration. And so they just can't focus. They can't learn new things. It's hard to complete tasks. It can be very disconcerting, particularly for our gentlemen who have this higher executive functioning. They're CEOs, they're businessmen, they're running around, they run their companies, doing whatever it is they do. And now they just can't get stuff done at the end of the day. And it's like, what is wrong with me? So sometimes that can be a sign of just too much estradiol. Gynecomastia, but this is a late sign. So I would not wait to test in on these things by waiting for the man boobs. We've got to check them sooner than this. So this is a really, really indicator of just hyper levels of testosterone therapy and a massive amount of conversion. Decreased libido, and I put a question mark here because again, they're talking about estradiol actually may be beneficial for libido. I think it's that sweet spot, just like it is for women. If women have too much estrogen, we don't feel good. And if we have too little estrogen, we don't feel good. And it seems to be, based on what I've been reading, that men are the same way. If we really drop it down low, we're going to make men feel menopausal. They're going to have hot flashes and night sweats and mood swings and not want sex and nothing works right. So I think we need a modicum of estradiol. We just don't want those levels to be soaring. It seems that this estrogen, high estrogen levels or high estradiol levels are highest in the 45 to 65 year range. So again, 65 and older don't seem to experience it quite as much. I don't know if they just don't have as much substrate or as much of the aromatase or what have you, but they're just not converting it as much. Higher in sleep apnea patients, higher in obese men. I forgot to add here also higher in your men who are getting injectable testosterone. So I would categorize under that either injectable or pellets, right? There's really not a great consensus on what the cutoff is for estradiol. What's an acceptable estradiol? I don't know. But the studies that I was looking at were looking at probably an optimal level between 35 to 45-ish. And then one of the other studies that was referencing that when they would start anastrozole therapy was if their estradiol level was greater than 65 or if it was greater than 42 with symptoms accompanied. So just something to keep in mind as you're checking your patients. But like you're not going to be screwing your patients over if your threshold is 50, or if your threshold is 35. I think that's okay. Just establish something kind of in your mind and your health practice where you're most comfortable sort of intervening. Okay, so this was interesting because it pisses me off. My daughters and I are always making fun of like little Brooklyn accents over here. So it really upsets me that we think of testosterone purely for men and we think of estradiol purely for women. But in my experience, Mother Nature doesn't make any mistakes. I was studying progesterone in men, actually, which might be another topic that we want to discuss at some point. But you could actually superimpose progesterone levels in men on top of progesterone levels in women at various age groups, and you can actually superimpose those scatter graphs. It's pretty remarkable. So men need progesterone as well. Men need estradiol as well. Why? Seems to be beneficial for libido. Again, we've always been taught that it's testosterone that is the driver of libido, when in fact, it seems that if we are lowering that estradiol super significantly, that it actually may adversely affect men's libido. Gaining and maintaining bone mass, tissue repair. So we'd always look at serum estradiol levels is probably the easiest way to assess, but it's kind of negating what is the cytoplasmic levels? What are the tissue levels of estradiol? So when we see testosterone, we have a traumatic brain injury, for example, we see that peripheral aromatization of testosterone to make estradiol at the location of the tissue to facilitate that tissue repair and to facilitate that anti-inflammatory benefit. So there is some of that peripheral tissue conversion, which is interesting. There's a role in spatial memory. So when we leave men alone on their testosterone alone, they have better spatial memory. They will get better verbal memory and verbal recall with testosterone plus anastrozole. So I found that interesting as well. So again, it's not one-stop shop. We've got to kind of look at that whole global clinical presentation. Where is our patient needing the most help? And that can kind of help to dictate, should we aromatize or not? Or should we block aromatization or not? It's important in gonadotropin release, right? So whether that estradiol is too high or too low is going to be signaling to that feedback loop to the hypothalamus and subsequently to the pituitary. Should we be making more of these sex hormones or not? Again, a target range somewhere in the order of like 30 to 45. And then this was a new phenomenon as well, but I was happy to see it again in some of the literature. I usually say in the literature, but I put all the references at the end of the talk. So if you wanted to pull the articles, they're actually fairly easy to digest. So the testosterone to estradiol ratio, if you go into Omni Calculator online, if you just even type in your Google search bar, right, testosterone to estradiol ratio, there's a calculator called Omni Calculator that I have found to be pretty reliable. So you just grab your patient's labs in front of you and you say, okay, the testosterone is 450 and his estradiol level is 62, and kind of look at what that ratio is looking like. I've seen ratio reference ranges anywhere from 10 to 1 to 13 to 1, so somewhere in there seems to be appropriate. If you're having something much lower than 10 to 1, it means you've got too much estradiol running around, and patients physiologically are going to do better when that testosterone to estradiol ratio is a bit higher. So if we look, here was just an interesting quote that I grabbed from one of the articles because I was just honestly too damn lazy to type it all out verbatim. So here we go. Scrap lifted from the interwebs. So benefits of estradiol in healthy males, irrespective of testosterone. So regardless of what their testosterone level, they're going to do well with adequate estradiol for bone mass and quality and anger levels, right? So she's going to be one of our calming friends and keep us from starting bar fights, right? But if we look at the estradiol and testosterone together, so looking at that testosterone to estradiol ratio, we're going to see better libido, improved cognitive functions, increased muscle mass, enhanced loss of fat mass. This may be true for women as well. Again, we're looking at this in the setting of men, but then I just academically put in my numbers and I'm like, shit, I've got too much estrogen. Being on hormone replacement therapy. So it's like, all right, I've got to balance these levels out and I'm probably going to feel less squishy, have less fat around the middle and so forth. So I think it can be true for women as well, but I haven't seen the studies therein. And I've done a lot of research for female hormone replacement therapy. So this would be curious to sort of do a study in your practice to see if that benefits women as far as a ratio as well. Increased basal metabolic rate, increased fat oxidation, reduce cardiovascular markers. And I think this is really, really big on the field when we're considering like, how are we helping heart health? There's so many docs who are fearful, again, because of urban myths and legends that testosterone is killing our hearts and so forth. And that really just may not be true, particularly with this intima media carotid thickness, or CIMT, is a really big indicator for strokes and heart attack and sudden cardiac death. So that's a really, really cool thing to be looking at. So that might be a target you want to keep an eye on. All right. What are some of the benefits of using these blockers? So the one that's primarily used out in, I think most circles is anastrozole. There's also letrozole, which is a newer agent, still third generation aromatase inhibiting. Fairly minimal side effects with either of those. You do see some tamoxifen. Tamoxifen is not an aromatase blocker. It's actually a selective estrogen receptor modulator. We'll get into some of the differences there. But when I'm talking about aromatase inhibition using either AI as an abbreviation or AZ is anastrozole, I'm primarily talking about anastrozole, so just for your own edification, but you could probably superimpose letrozole on most of this. It stimulates the production of LH, FSH, thereby lowering estradiol, or excuse me. So if we just use anastrozole, let's say we're using this in the absence of testosterone therapy per se, it's going to stimulate LH and FSH because it's lowering estradiol. When we have a lower estradiol level, the brain sees that and says, oh, we need more hormone production. So it'll increase that LH and FSH secretion, which will in turn stimulate those Sertoli and Leydig cells and help us to produce sperm, but also to produce more testosterone. Remember, those guys come from different signals, different parts of the testes. It's sort of mixed. It looks like there's maybe a better sperm amount, but some studies show better motility and form and others don't. Not showing a significant difference. So that one I would say the jury's still out a little bit on, but it's curious, especially for your men who want to preserve fertility, that maybe starting them on a low dose anastrozole might be beneficial as opposed to testosterone therapy, which would suppress sperm production. So it can likely cause testosterone levels to go up without testosterone replacement therapy. And it looks like the use of anastrozole on its own for this element gets you to a physiologic level, but they didn't define what is physiologic level, right? Are you going to get to 302, which technically puts you outside of the range of testosterone deficiency, but it's not really optimized? Or are we looking at levels of like 700, 800, where you're really feeling good? So that's what I couldn't glean from that literature, but maybe if I dug down a little deeper into results, I'd find it, but I didn't see it. Can delay the closure of epiphyseal plates prior to puberty or during earlier puberty. So this will be for your little males, right? So your young men who are coming in and they're smaller in stature, slower growth curve, their peers are all passing them. You may want to consider a little bit of anastrozole to kind of help delay some of that epiphyseal plate closure and help them get a longer growth curve. So not necessarily faster per se, but a little longer. And then using that with some growth hormone or other gonadotropin peptides may help as well. Might help delay that puberty, again, for those short stature boys. Really mixed benefit for gynecomastia. We kind of originally, I think the idea was like, oh, shoot, your men are growing breasts. Let's put them on anastrozole and that's going to reverse it. It doesn't reverse it. Maybe it stops it, but really most of the time it's because your men are hyperdosed, right? They're overdosed on the testosterone. So lower the offending agent, don't necessarily just block its effects, right? And long-term use does not seem to affect bone mineral density. Again, there are a couple of earlier studies that showed maybe it did, but then now it's saying no, it doesn't. And so you just have to like kind of pick out through the literature and see what seems to be making most sense for gentlemen. So again, that anastrozole can raise the testosterone level because it blocks the formation of estradiol, thereby stimulating FSH and LH, stimulating testosterone production. Daily dosing might be up to 1 milligram PO daily. Oh, another type. So that said, when we're dealing with testosterone replacement therapy and aromatase inhibition, we're typically doing like 0.5 milligrams 3 times a week, as opposed to a 1 milligram daily. But if you're using it for building a gentleman's testosterone solely without testosterone itself, it looks like it's a 24-hour physiologic restoration. So we're getting those numbers up there to physiologic range. Again, whatever that range is based on that study. I didn't see if they gave me an actual serum testosterone level. They just said physiologic levels were restored. And so, but you would need to do daily dosing to sustain that. And then we're not getting super physiologic levels. So this is nice. So even for your gentleman who maybe takes some testosterone, but they get up to like 2,000, or 1,500, they're super, super high levels. Bring them back down. Maybe just try a little anastrozole. They might respond really well. Okay, so talking about different aromatase inhibitors, what are the things that can work? So anastrozole, we've been mentioning, is a 3rd generation aromatase inhibitor, 0.5 milligrams 3 times a week, or up to 1 milligram daily. So as I was starting in this venture, I'm just kind of reading articles and they're like, yeah, just give anastrozole 1 milligram a day. Okay, I guess. That's what we use for women. Sure, why not? But it can cause some weakness, headaches, hot flashes, night sweats. It typically won't, though, because one of the benefits of anastrozole is it seems to block some of that aromatase, but not plummeting men's estradiol levels so low that they feel like a menopausal woman. So I think we're still like at 0.5, 3 times a week, or even 5 times a week. One, just back off on your dosing of the testosterone, right? But also then you can play around with that anastrozole and probably not cause them too many side effects. Most of the studies showed that there were not a lot of side effects or adverse effects from being on anastrozole. However, with tamoxifen, I think the opposite is true. I think that most gentlemen have quite significant symptoms of like night sweats and flushing and abdominal weight gain and weakness and muscle loss and sexual dysfunction. And I see this primarily with my gentlemen with prostate cancer who've been placed on tamoxifen. And they're really blocking those hormone levels. And they're not happy. They feel like shit. So it's just not ideal. So it's one of those things I would be more cautious of use of tamoxifen unless your patient's coming to you maybe from another practice. They're just transitioning care and they want you to continue on what they've been using because it's working. Great. If it's working, I leave you alone. To that end, I have some patients on oral Premarin. I hate it. I think it's the worst type of estrogen therapy you can implement, but they're happy. They've been on it for 25 years. Who am I to tell me, right? Okay. Sorry, I'm still trying to help that throat. Okay, so let's talk about DIM. DIM is a natural element. It stands for diindolyl methane. It comes from cruciferous vegetables like broccoli, Brussels sprouts. But in order to get enough aromatase inhibition from broccoli and Brussels sprouts, you need to eat like 4 pounds a day. And nobody will want to live in the same household with you if you are cooking up 4 pounds of broccoli a day in your kitchen. Absolutely not. So while it's not a bad thing to be eating these things, I think you can't get enough to get that aromatase inhibition benefit. But it is available over the counter. So you can be on like Full Scripts or one of these other elements, Get Healthy. There's a variety of different forums where you can make a recommendation of a certain brand of DIM to your patients. So they can get that appropriate brand and not just go to like, the grocery store, or Walmart or wherever and get like knockoff brand, right? We want a good, reputable, quality brand that doesn't have contaminants in it. But what it's doing is actually pushing that conversion pathway. Instead of going from testosterone to estradiol, we're kind of pushing that estradiol then to become 2-OH estrone, which can then be methylated and removed. So that's going to be a better ability to clear utilized hormones instead of just leaving them floating around for resorption and deposition into fat tissues. So that's a really good tool. The other great tool, if you've never been to my menopause seminar, you should do it. So I just gave it this last weekend. It'll be up on my website in the next week or so. The girls are just revising little parts of it and going to go ahead and post it on my website for purchase. Is calcium D-glucarate. So the person who taught me about this is my nurse practitioner, who's amazing. She specializes in detoxification pathways, methylation pathways. So she gave a great talk on the Sunday's lectures about aromatase, clearance, hormone clearance, how your cytochrome P450 pathway works and so forth. So calcium D-glucarate is a fantastic tool for helping to block some of this. And what it's doing, it's not really blocking aromatase. It's actually just inhibiting that reuptake of estrogen in that liver. I think it's phase 2 metabolism. So it's helping to augment that liver metabolism, and as a result, then lowering those estradiol levels. So actually, having looked now at my testosterone to estradiol ratio, I'm actually going to start on calcium D-glucarate as soon as I can get my little patty paws on some. So it's really cool. As we know more, we should, know better, we should do better, right? Okay, so should we be blocking this or not? One of the really cool studies that looked at this was very interesting to me on a number of levels. They look at 1,700 men. Again, this is referenced in my references slide at the end. I just hate putting the little tiny references at the bottom of the slide. So they looked at 1,700 men, but only like 55 of those men actually needed aromatase inhibition. Only about 2.5% had elevated estradiol levels, either over 65 or greater than 42 with symptoms. So I think that's a take-home point, right? Not every man who's on testosterone therapy needs aromatase inhibition. That's where you want to follow your objective data, look at your labs every few months, see what they're doing, and also based on clinical presentation. So if you're checking their labs, that's also an opportunity for you to check in with them clinically. Hey, brother, you gained like 15 pounds. Yeah, bro, like I'm at the gym and I'm getting bigger, right? Or yeah, I'm getting really heavy, like my pants don't fit. I'm having to go up a size. Okay, well then those weight gains are not the same, right? So we need to kind of look in on our men as well. So they were the men who needed it, these 55 or so men who needed it, were put on an anastrozole 0.5 milligrams 3 times a week. And it looks like the average time to have to start anastrozole was almost a year. After initiation of the testosterone replacement therapy. So they were not having to go on it within a month of starting therapy. And again, this is what I was taught, is that usually within about 2 months, they're not going to feel great on their testosterone. They're going to start feeling really dumpy, grumpy, pregnant woman-like. And it looks like, at least in this study, that wasn't the case. It really took a while for it to start processing into higher serum levels of estradiol. Of the men who were started on anastrozole, 88% of them showed a lowering of estradiol down to physiologic levels, so something between like 30 and 45. And none showed such severe lowering that the E2 levels plummeted to those sub-physiologic levels. So that's really good. So again, we're not going to overdose these patients to where they now have the effects of, the hot flashes and night sweats and so forth. There were no adverse side effects with this particular regimen, so I think that's important. But what's also important to remember is that was with 55 men who were treated with anastrozole. So can you extrapolate that out to general male population? Kind of a stretch, but again, something to consider, that maybe this is an appropriate dosing where we're not bottoming out their estradiol levels. It seemed that the lowering of the estradiol levels did not necessarily improve their libido, but it also didn't detract. So it was just kind of no change. And it seemed like there was no clear cutoff for when to implement anastrozole therapy. So while they put in these sort of regimen of greater than 65 or over 42, it sounds like it was kind of still arbitrary. So even they weren't happy in their own study to say like unequivocally, this is when you need to start men. It's like, hey, these are the guidelines we use. Maybe this is going to help you, but we need to study it further. And I think that's a really respectable conclusion to draw, so that we have respect for kind of what do these studies actually mean and how can we push that forward to our population and practice. Again, as much as I wanted to dive into 87 different articles, I really just maybe found 5 or 6. I think the newest article I found was 2021. There's quite a few blogs and vlogs, things like this out there from various clinics that are touting why they're doing testosterone therapy better. Come with us. We have peptides, we have DIM, we use this, we use that. So I don't know how much they were based in science, because again, it's somebody's like editorial. It's like if I write something up like this and publish it, well, that's not a scientific study. It's based on what I've read and what I know to be true in practice. So I'm not saying they're full of crap. I'm just saying that also from those blogs, you can glean some information, maybe some key tips that you want to try and practice, particularly if it's not going to harm a patient, but maybe not something that's perfectly like evidence-based. And it's where we get into the art of medicine rather than the science of it. Again, as with other types of HRT, much of this practice has been just based on myths and legends and, hey, this is what I've done, so this is what you're supposed to do, which is not necessarily true, right? I mean, we do a lot of things that we shouldn't necessarily do. We used to deliver babies without washing our hands between patients, and we had super high maternal mortality rates. Now we wash our hands between patients and use gloves. Imagine that. So I don't know if you knew that historically, but we used to, as doctors, who know everything, right? As doctors, we would go in and do a delivery, and then we would go down to the morgue and examine the patient who died maybe of postpartum fever, which is basically, postpartum endometritis. And then we'd go back up to the floor to go deliver another baby. This was before the advent of gloves and certainly before the idea of hand washing. And we had really high maternal mortality rates versus our midwife counterparts that were like, dude, why are you guys killing all of your patients? And it's because they would wash their hands in between and they, get all the blood off of their arms and so forth. And we were just flippantly going around all over the place spreading E. coli to our patients' vaginas and uteri, which is fantastic. So we can always learn more as physicians, right? Little is understood about the benefits of each of the sex hormones, particularly for the opposing gender, right? So we're not going to get into transgender and how many genders are out there. We're not having that discussion today. So assuming there's male and female. Men have benefit from female hormones in their system, and women have benefit from male hormones in their system. They're just oftentimes at varying levels, right? So my women, I like them to have a DHEAS level of about 200 to 250. With men, it's got to be about 400 to 450. Women, average testosterone somewhere between 25 and 50, 70, somewhere in that range, versus men, again, 700 to 900, 1100, they're going to feel really good. So, but we still need our other counterparts. They're balancing each other. It's a symphony, not just a one, it's not a one-man band. We've got to have all these little players. It appears that estradiol plays this important role in tissue support and repair, and anastrozole has its own benefits just as a monotherapy. All right, so what are my overall recommendations? Check your labs, get a good idea of the lay of the land, figure out what's going on with their patient. I just had a young gentleman, he's 28. He says, I think I need testosterone. He really struggles with mental health issues. He's kind of up and down, probably bipolar. So he's working on that mental health aspect of things, but he's like, I just need testosterone. I'm like, oh God, if you're in a manic state, me giving you testosterone is going to be the worst thing I can do, right? But what are the rest of his labs? What's his liver clearance? What's his homocysteine? What's going on there? So until he gets labs, I'm not touching him, right? So just because a gentleman comes in with low energy, fatigue, poor libido, doesn't automatically mean testosterone's the problem. Again, only treat if needed. I tend to treat hormones with a very big respect. I don't want to just put every man I see on testosterone therapy, especially if they've got sleep apnea, if they've got uncontrolled diabetes or suboptimal diabetes, right? I like my folks to be with an A1C of about 5.5 or less, down to about 5. If they're getting into the 4 ranges, they're not getting enough glucose to their tissues. So optimize those things as a priority. Again, you might be able to use anastrozole as a primary therapy. Follow labs, she says again. So make sure that when you're implementing a therapy or a change, some kind of lifestyle, whatever it is, check labs again, see if what you're doing is working. And then if it's not, do something different. I really like to avoid those super therapeutic levels of testosterone. Again, more is not always better. You want to keep an eye on that. Continue to analyze, keep your eyes out for that literature, or maybe you guys are more funded than I am and can make your own literature, case studies, small case trials in your practice. I keep saying I'm going to do it. I lack the organizational skills to probably facilitate it. And then follow labs, follow labs. And again, I like following those labs because it gives me that opportunity to meet back with that patient and see what their clinical presentation is, as well as their objective findings. So it gives me that combination, which again speaks to that art of medicine as opposed to just chasing numbers, right? So really, really important. Okay, and then assessing the patients individually. So again, that interval of checking labs, I usually like to check every 3 months or so. If your gentleman is stable and he's been on the same therapy for a while, he's busy, he's traveling for work, he's in Bermuda, fantastic. Don't come back from Bermuda just to check your damn labs. I'll see you in 6 months or a year. So I have some gentlemen who are very comfortable with that. But when I'm initiating therapy, I like to really keep a close eye on them and make sure they're not having super huge metabolic swings in their levels. Look at absolute values and these ratios. I think that that's a really, really important key factor that I picked up from studying for this. And I would consider really that troche is my personal favorite for gentlemen. Then I would say second would be topical, so your gels or creams. And then lastly would be the injectable, either with just a depot injection versus the pellet therapy would be my least favorite. Clinical presentation and objective, I think I've beaten that horse to death. And then optimize your detox pathways. Make sure they're on milk thistle. Do they need to be on a liver gallbladder blend it's like bovine liver complex something. There's a lot of these agents out there that will help. Dandelion root is another great liver detoxing method. So make sure that's optimized. Optimize their methylation. Just being on methylated B vitamins, a methylated multivitamin can help optimize their vitamin D. Limit the estrogenizing exposures, alcohol, phthalates, plastics. So even just touching receipts from CVS or Vons or wherever you're grocery shopping, just touching the plastic bags, touching the receipts. Remember, our skin is our largest organ, so we are always absorbing through our skin. Everything that we touch is getting into our system. And it's a beautiful thing because it's telling us about other and self and am I in danger, right? But then we're absorbing all of these things as well. And if our detox pathways suck, we should just also limit the amount that's coming in. So again, trans fats, ultra processed foods, alcohol. Sorry, alcohol is only inflammatory. Not that I don't like to enjoy a cocktail here and there, but I also know it's going to screw me up. So as long as I'm willing to accept that consequence, then I don't need to go up or down on my hormones. I need to stop stepping on the thumbtack, right? Stop doing the thing that's harming you. Okay, so that kind of concludes putting a lot of that together. So hopefully we left enough time for discussion after. This is how you can get a hold of me, particularly if you're choosing to do any of my mentorship, or if you want to find out how to get that menopause seminar for how to institute. And that's where I get into actual logistics of these are the lab levels I like to see for my ladies. Here's how you write a prescription for a cream. Here's how you write a prescription for a transdermal patch and so forth. I really get into it. So it's a super cool presentation. And then I'm trying to get up to 5,000 followers on my Instagram. So if you want to follow me, it would be an honor. I'd be super, super appreciative of that. It's just a personal goal. It has no bearing on any part of my life otherwise, except just I needed something to put on my vision board. So again, here are some of those references. Pretty limited, guys. It's just that one page of references because I didn't find a whole ton of stuff out there. But it's hopefully going to get bigger.
Okay. Thank you so much. Not very much information in the chat or questions. Just Dr. or Stefan. Microdosing injections, alternating days or even daily of testosterone cypionate, 10 to 12 units daily for men, or 200 milligrams for ml. I'm not sure what you mean by 10 units is what, 1/10 of a cc?
Yeah, it's 0.1 ml.
Okay. And then
Yeah, and I've had some patients do the microdosing. I think it just comes back to be honest, and to all the gentlemen in the room, I love my mans. Men's are amazing, but y'all are big fat babies too. So a lot of times there's some reticence to do like daily injections or 3 time a week injections. Now some do, particularly if you can get it through like an insulin syringe, so very small, like tiny caliber syringe. So like our BPC patients and that sort, they are using it mostly daily. But with the testosterone cypionate, it's an oil base. It's a really thick solution. So sometimes you're having to use a wider caliber needle and it hurts. It's also got to be intramuscular, not sub-Q. So that makes it a little bit more sensitive, prone to bruising. But yeah, I'll have patients who take it several times through the week as opposed to just a once a week dosing of like 200 milligrams per ml. And then they trough towards the end of the week. They're feeling pretty crummy by Saturday if they dose themselves on Monday.
okay. All right. And then there's mention of a certain supplement companies making nano emulsions available. I won't mention this because since we still have the CME going for compounding pharmacies, sublingual LH is not suppressed, so less rise in estradiol. So Dr. Nario, do you have anything online?
Yeah. So a great presentation, Dr. Jackie. One of the things that was mentioned here was you mentioned that you wanted to fix the metabolic issues first, or correct me if I'm wrong, before giving them testosterone. Is that something that you're emphasizing, or you can treat them in concomitantly with the comorbidity? I think you mentioned about diabetes and sleep apnea, I think.
So there's best practice, right? In my optimal ideal world is that we would totally get your diabetes and your sleep apnea under control before we implement testosterone therapy. But in my practical experience, what I find is if you don't even have the damn motivation to get off the couch and you're falling asleep snoring on the couch because you can't get your butt to the gym or make a meal because you're like snack foods because you don't have the energy to do it, then I treat them concomitantly often. But I really emphasize it like, brother, this is not going to be the only tool. We've got to do this as a whole picture. And that's why I developed like the holistic integrative type approach, is because I think we've really compartmentalized medicine where we're like, okay, well, I'm your testosterone doctor, but you need to go to your endocrinologist for your diabetes. And then you need to go to your gastroenterologist to fix your gut health and your hepatologist for your liver. And unfortunately, our patients are running all over ragged and one hand doesn't know what the other hand's doing. So if we can have a whole understanding of how these metabolic pathways play off of each other, and then that detoxing clearance, blood sugar metabolism, chronic hypoxia all affects those testosterone metabolic pathways and clearance, then we have a better approach at implementing therapy.
Yeah, one of the bigger controversies when I was lecturing, I was lecturing in A4M during the spring conference. One of the bigger questions that they had was this controversy about should we treat low T while they have sleep apnea, right? So I think the worry there is actually increasing the hemoglobin hematocrit when these patients are hypoperfused. So one thing that was brought up there that definitely you can. It's just a matter of really monitoring the testosterone levels and also the HNH while you're trying to fix, of course, weight loss and also the sleep apnea issue. So, but anyway, to answer that question, you definitely do address that and at the same time monitor the whole situation while you're actually addressing the problem. One question here is experience with the different forms of testosterone, such as intranasal and on the canoate version. So these are probably the newer ones that are out there. Do you have any experience in relation to treating your T's in your men?
Yeah, I would say I don't have any experience with the intranasal or some of these newer formulations. I think there's a lot to be said for it, though. I looked back at the intranasal progesterone study. It was only like 11 patients, but it seemed to have really good bioavailability, good absorption. So probably true for testosterone. Progesterone is one of the heavier molecular weight hormones. Testosterone's a little bit lighter. So I think if progesterone's perfusing across that nasal mucosa, probably testosterone would too. maybe having better brain effects. I don't know. And then with that peripheral tissue conversion to estradiol for tissue repair, maybe better for cognitive health. So I think this is where it gets so exciting and innovative, is that there isn't just one way to do it. Again, I didn't even know about troches when I started this 6 years ago. I was like, wait, troche, what, how do you spell that? I had to have my compounding pharmacist like spell it out for me so I could write the damn prescription. So it was a matter of just learning and having that clinical experience of seeing that my patients had less of that peak trough phenomenon with the daily troches, as opposed to being on an injection and having a peak trough, because all I had known as injectable. So I think it's interesting. It's going to be cool times in the next 10, 15 years as we're learning more about it.
Right. So for the intranasal, I think the claim to fame to that is the less suppression of course, your own endogenous testosterone production. The only drawback with intranasal, though, it's 3 times a day. You're talking to men who's hardly even taking one supplement a day. And also the side effect, right? So really the compliance issue with men is one of the bigger questions there. And the side effect. One of the side effects of this intranasal one is the stuffiness of the nasal passages. So you're basically almost like really congested when you're using this. But as I've said, it's one of the, I haven't done much of this, but really we're worried about for sperm production.
Also $800 a month.
That too, for sure. So, but I'm sure there's a compounding pharmacy out there that's probably gonna wiggle themselves through it. So
yeah. And with my troches, because again, this is my menopause seminar where I do a cost breakdown of like, how much do these things cost? Because everybody imagines that, compounding pharmacies are so expensive. And it's about 60 or 75 bucks a month, 55 to 75, somewhere in that ballpark a month for the troches. And so that's not that expensive, really. Again, I can pee away 110 bucks just on sushi tonight. So, and I have no shame in doing that. I will spend that all day long. But when you consider like, hey, this is something that's going to get me that motivation, it's going to help me fix the plumbing underneath the sink. I can, change out and organize my garage. I can finish the PowerPoint presentation for work. I think it's super worth it. I do a lot of biotoxin illness work as well. And one of the therapies is to use VIP nasal spray. You have to follow lipase levels. You have to worry about pancreatic dysfunction, and you have to use it 12 times a day. Keep it in the refrigerator. I am not near a refrigerator 12 times a day. If I were near a refrigerator 12 times a day, I'm going to weigh 422 pounds. So it's not, to me, it's not practical. And again, it's like 700 bucks a month or something. So the practicality of some of these approaches, while I don't think they're bad ideas, I agree with you. I mean, it's, what do they say? Like 75% of male appointments are set by their wives, right? Men don't initiate their healthcare. They come in because their wife told them, I'm feeling fine. I don't know why she made this appointment. She said I should check in. So then to also ask them, hey, do this thing. Don't worry if you're traveling for work, just pack it in your carry-on. And then some rogue TSA officer throws it in the trash can and there goes 700 bucks. I mean, they likely won't because it's a prescription, but you follow what I mean. Like the practicality of it is going to be difficult, I think, to be compliant.
You're being very generous about 75%. So I think it's higher than that, but okay, we'll take it. Men won't
trying to give the benefit of the doubt. Be nice to my men.
All right. Well, the other one with the candleweight one, I think the claim to fame to that is it's a PO that is not affecting liver function. So methyl testosterone was out there once that actually has been known to aggravate liver enzymes because of the alkylation that's involved when you convert testosterone when it goes through the first pass effect of the liver. And this newer one actually is claiming that I haven't used it. It's actually not going to elevate these liver enzymes. And also it even helps with NAFLD. That's one of the things that was shown in the studies for this. And again, injectable version of the indicanoate, you just do it 3 to 4 times a year and you maintain such testosterone levels. So I don't know if Dr. Bill, if you have experience with that, but I don't have any, but it's just something that's out there that's starting to make waves. So
one of my colleagues has been using the testosterone decanoate product, but all the patients that I share with him are requiring 800 milligrams, of the product daily, and that you got to be wealthy to afford that.
Yeah.
It's like crazy expensive.
Mm-hmm.
Yeah, I've never heard of the dose, but that is a huge dose, and yes, of course, the price.
Well, they start them on 200, and nothing raises. And 5 of my male patients are on stabilized on 800 milligrams.
What did they do for work that they can afford it? That's what I'm always curious of.
They've got a really rich oldest brother, and he's taking care of his siblings.
Yeah, I need a rich older brother. I just have a broke older brother.
I think Kent will adopt you.
A great presentation, Jackie. I may
Yeah.
a little bit interject here. I'm another word.
I tried calling
more,
you earlier, Dr. Halassa, and we missed each other. I was seeing patients all day.
Oh
Sorry.
yeah, don't worry about it. Yeah. But I just want to add more to what I don't like to give in the beginning the end products of the 6 hormone, which is the estradiol and testosterone, as much as if we can look at what the lab. And I think when I have a visit with Stefan, I like Stefan way of doing things, which he is looking at all the labs level of DHEA and prognolone and progesterone, and seeing those the executive, the upper molecules, which are the food of the 6 hormone, the progesterone, the DHEA, the prognolone. Those are the precursors of the ends. And the reason, because when you give them the ends, you end up causing gonadal atrophy. And so I think it's better if we test all those ingredients and see what's deficient. And I like to start with progesterone and prognolone. I will start with prognolone in the beginning, and then go to progesterone and see the DHEA and feed that. Make sure that that's being normalized before I start giving testosterone and estrogen. And if we can, I mean, I know, some people, they want to give that rapid effect, so the patients feel comfortable and good, and then he will come to your clinic. That some way of making them feeling good, but at the same time, while you're doing that, try to work on those upstream ingredients, and wean down the downstream as much as you can when things it's getting normalized. And as you said, detoxing the body and improving the liver function test, because liver is very important to get rid from all this xenoestrogens and all this bad steroids. So yes, everything that you do for improving the liver function will help to get rid from all those waste. Adding cyclodextrin, it's very important. That's something I entertain a lot, because those xenoestrogen and microplastics, and all those, you cannot get rid from it easily. Cyclodextrin will be the answer, along with improving the liver function, because those cyclodextrin works like a high density lipoprotein, but better even, because it takes care for xenoestrogen, microplastics, and all the wastes, and dumps them into the liver, and some of them into through the urine. And sweating and sauna is very important. So when you have a clinic, the optimal clinic has to have some gym next to it, like what Stefan is doing and what I designed for chronic disease prevention management, because that gym next to the clinic for integrative doctors, it definitely helped to add value to your practice. So I like Stefan's way of practicing medicine. I stayed there one day, and definitely he is helping a lot of people. But his methodology it's more comprehensive and to the teeth. But adding, as I said, start with supplements, feeding the executive, especially progesterone, prognolone. Progesterone is very important. I don't think it's the right thing to give testosterone without progesterone, because progesterone would help to put the brakes over the aromatase itself. Also, it helps to put the brake of the conversion of the testosterone to dihydrotestosterone, because we know there is a problem with excessive dihydrotestosterone itself, and causing hair loss and possibly some prostatic problems. So feeding the body with progesterone, I think Dr. What's her name? Peterson, she's here. She will definitely raise her hand and say, "Hey, where you missed progesterone?" And she's a walking progesterone, by the way. And you can see that she's doing very good with it. You can see her hair is thick and long, and she feel happy and all that because she's feeding the executive molecule versus the end users. Because those end users, as much as you don't give them, I mean those estrogen and testosterone, as much as you don't give them, it's better, because then you rely on your endogenous sex hormone. So that's my take in this. But your presentation was to the teeth. The other thing is transgendering thing. That's something we need to talk about. People are transgendering and giving the sex hormone extras for female and men. This will compromise their metabolism, and they will end up with metabolic syndrome, because men has testosterone dominance, and when you give them extra estrogen, you counteract the testosterone, then they will end up with metabolic syndrome and a lot of things. I have a book on that. It's called Estrogen Dominance Syndrome. Actually, it leads to depopulation and decrease the number of men by this estrogen dominancy. It has effect on even Y chromosome and X chromosome, where estrogen dominance and oxidative stress that comes along with it leads to reducing the number of Y chromosome. And then you have a lot of female, more than men, and then you have the depopulation rate. So anyway, the transgendering versus embracing the sex hormone treatment, which I think that's the best way of doing. That needs also some sort of a campaign from the doctors to encourage embracing gender versus transgendering, and treating it the way as we are doing is to normalize the sex hormone.
Dr. Sammons or Dr. Clearfield,
yeah.
Without overdosing, have you encountered causing cardiac disease with routine testosterone replacement?
Actually, I find the opposite. I find that it actually improves cardiac disease, and we have much less cardiac incidents. This sort of came to a head in our practice here. I think it was 2 summers ago. I had a patient of ours call on a Monday, said he had had a heart attack one Friday night, and he was in the hospital over the weekend and had a stent placed in. He just wanted to let me know. And I remarked to my assistant, who'd been with me about 6 years at this point. I said, "When was the last time we had a patient that had a heart attack?" And I come from a place where we had 3 MIs a week in our practice. And
wow.
So is there any concern of increasing adrenaline as a result of the hormonal replacement?
It's not been my experience. I don't know anybody else.
I haven't seen it in my practice. I actually have a cardiologist who works here at the practice as well, and he really likes optimizing hormones for the benefits of dyslipidemia and cardiovascular markers. I think we're seeing more of this in the women's space. It's been a huge controversy, I agree, in the man space. But I think a lot of that concern comes from the days of overusing steroids, overusing testosterone in the 80s, where everybody's bulking up. And we were seeing, the hypogonadism, the shrinking of the testicular atrophy, and then cardiovascular events. So I think just when we're super therapeutic, we're not doing our patients a benefit. But I would argue that I haven't done it enough in my practice to really see like a major change of like, oh yeah, none of my patients are having heart attacks anymore. Not really. I don't know that I can make that statement.
Yeah, like I said, we've seen very few patients with MIs, here. I mean, and I have patients that are in their 80s, that using testosterone for 20 years.
One of our compounding pharmacies, we have at least 20,000 men on testosterone replacement, and for a 4-year period, we had no one that was regularly coming to the pharmacy and getting their hormones filled that had a cardiovascular event. But then we also use, Arterosil HT to fix the glycocalyx.
I may challenge that. I really may challenge that. The practice that Dr. Stefan and Dr. William Clearfield and Dr. Jackie and Dr. Nayu, they're not really just throwing testosterone by itself without looking for optimizing the health. If you really throw testosterone without looking for all other things, we're talking about the weight loss and optimizing the sex hormone and reducing the estrogens and looking and checking and balancing it in a normal, yes, you will end up with stroke. So let's give the right answer, yes, because this testosterone, throwing testosterone to a man and he is obese, and the fat tissue will convert everything to estrogens.
No. I'm not referring to that. This is
I'm just saying
care.
There is a point of there. What I'm saying is that people, this person who asked a question, yes, if the doctor is not experienced and he's giving testosterone only without,
absolutely, 100% agree,
they
Dr.
will end up
Alasa.
with stroke.
Yeah.
Part of it increasing the hemoglobin, part of it increasing the estrogens. You will end up with a problem with it. But as long as you're doing it in a balanced way, that's why Dr. William will never see any case of that, because he's doing it in the right way. That's
I
why.
think
also responsibly dosing, right? Responsibly dosing, so we're not these super physiologic levels. Like some men have asked me, and I'm like, I'm really not the practice for you, right? Like, I don't want your levels floating around at 2,000, 2,500. So even in the setting of like, they're working out, they're eating clean, they don't have diabetes, but you're super therapeutic, I think there's still some inflammatory hormetic effect to these hormones that we also don't want women on estradiol to their levels being 300. That's why I dislike the use of pellets. I've seen women with levels of 279, 300 on their testosterone. I'm like, what the hell are you doing? Like, that's way, way, way too high. And their estradiols can be upwards of 500, 600 when an optimal level
great.
of
Well,
about
that's why
42.
they tell you not to do the test on a pellet. I think it's the wrong way to go around hormone replacement.
We don't really use the serum levels for especially in women.
Yeah, you don't test on a pellet.
The serum levels and the tissue levels are not the same. We usually go by symptoms.
Just to give you some fresh off the cusp literature here, that recently, February 2025, FDA has now removed the black label on testosterone products in relation to its correlation to their risk of producing increased cardiovascular risk. So the black box warning is now removed. And you have to remember, this came from the Traverse trial, which actually, again, have proven that now the stance of FDA with the testosterone, they're neutral. But the only thing that stands with their recommendation is there is still a possible increase in blood pressure. So even the FDA now had folded in terms of the correlation of cardiovascular risks in terms of being part of testosterone's profile is gone. So this is fresh off the press, just to give more substance to answer to Dr. Crouch about what he was asking for.
Dr. Henario, if you'd been at AMMG instead of A4M, you would have heard me talk about the Traverse trial. They asked me to do that. And the problem with the Traverse trial was that they used one product, which was a testosterone 1.62% patch made by the company and it's sponsored by the company that makes that patch. And that's all they used versus placebo.
Right.
So you would expect higher blood pressures because those are synthetic at the testosterones.
Right. Well, now again, we can tell our
patients
patients about the cardiovascular risk. Even FDA saying nope.
They also said there was a higher.
And this is what I look at even with like menopausal hormonal replacement therapy. Is even with crappy estrogen, you're still getting a reduction in mortality. You're going to get a better reduction in mortality statistically if you use bioidentical. But even with crap products, synthetic testosterone, synthetic estradiol, and so forth, or, conjugated equine estrogens, you're still going to see a benefit. And it's encouraging that they've taken that black box warning off. Now we have to do vaginal estradiol, right? If we can get on removing that black box warning about it causing cancer when it doesn't, that would be super for removing fear from the hearts and minds of our patients.
The other one of the other,
Dr. Jackie,
yeah, well, one of the other
you did mention about the hormones that there's now a 10 million study showing that. So the controversy of the window of 10-year over 65, this 10 million study for women had actually shown that even they said the crappy estrogen and also the crappy progesterone with
the
medroxy
progestins
has still been showing benefits for these women.
Yes.
That's why the 65-year-old big question of like, don't stop the hormones when they get there. Don't even start it. This makes you think twice.
I tell my patients you can come off your hormones when you're ready for your tissues to decline.
Right.
Otherwise, stay on it, maintain those tissues, and if I have it my way, I will maintain tissues until I croak it or get hit by a bus, and then I go toes up. That's it. I don't want slow, steady tissue decline for the next 40 years. Thank you very much.
So, okay, so one of the raging controversies at AMMG is several of the physicians have decided that using estrogen aromatase inhibitors in any form at any time is akin to malpractice. And they don't care if the estradiol levels in men get to 150 or 200. In fact, one of the practitioners himself, he states he takes estradiol 7 milligrams a day orally. And that his goal for men is testosterone levels of 2,000.
Yeah.
And this has been a raging controversy, and he's got a few points that I sort of conceded. So we used to control the estradiol levels. Originally so way back when in the dark ages, when we first started doing this, we didn't have really any guidelines to go on. We just kind of followed the gym rats. And so we would get testosterone levels to 1,500, and we would give aromatase inhibitors, so the estrogens were read 0. That didn't work out so well. Then we kind of settled on 15 to 25 as sort of an ideal estradiol level. With anything over 40, we would inhibit. Now I've sort of changed it. I've changed up, and because there are some studies that show very low estradiol levels create a high increase in osteoporosis in men.
Yeah.
And
bone resorption. Yep.
Estradiol levels that was thought was a cause of cardiac disease actually protects against cardiac disease. And again, it makes sense. There's shouldn't really be any much different between men and women. And when you go through menopause, your osteoporosis and heart disease and dementia are the main maladies. And so my practice now, we don't block the estrogen levels at all unless they have some sort of gynecomastia, some sort of mood disorder. And then some men have better libido and erectile function with high estradiol levels, and some have worse. So that's kind of an individual thing. And other than that, we leave it alone.
I think it's that clinical presentation. And I think that let's not throw the baby out with the bathwater, right? So it was interesting when I was doing this research that they're looking at aromatase blockers as a primary therapy to help build, intrinsic testosterone production. So I found that fascinating. And I think that if we were to look closer at not just estradiol levels, but what is it converting to? Because if we're getting it converted over to that 4-OH estrone, so more of our inflammatory proliferative type of estrogen, that's when we're going to have higher levels of inflammation and I think higher levels of symptomatology. So that's why I included in the screen that I pulled back up my lab evaluation. I'll often look at either total estrogens or estrone, not only for my women, but also for my men, and see what are they converting? What are you doing in there? Are you getting rid of the excess? Are you holding on to it? What does your liver look like? And making sure that they're using and clearing. We don't like to just recycle hormones. It's not optimal. So I am really excited to be part of this forum because I think there's a lot of insight here and everybody's coming to the table with different clinical experiences. It's been super enlightening. I'm super jazzed right now.
Well, please.
Maybe I need a different
I just
hobby.
want to
I
ask
don't know.
something to Jackie about your ratio. I think the 10-10 I think is low. I think 10 to 1. I think it's good to do for men 30-1 testosterone to estrogen. Do you
Yeah, I
agree
saw
with
some
me?
other stuff that said like 20-1. I mean, it was kind of a little bit all over the place. And for me, it was something like a very new concept because I hadn't even really
Right.
looked at it in
I
that
think 30 to
realm.
1 is the best ratio for men. And if you hear what Dr. William Clearfield about, people are promoting throwing in the ends of the sex hormone, which is testosterone, estrogen, at high level. Those high level, uncontrolled, unbalanced, with no understanding of the ratio, 2,000, 3,000 testosterone and 500, 600 estradiol, those eventually they will convert to estrogens, and they will lead to inflammation, and they will lead to cancer,
Yeah.
and they will end up with stroke. So the whole problem is not the supplements or the sex hormone. The problem is the lack of the right education where it needs to be practiced right. And if the FDA enforce into that, those doctors has to go through education and certification in order for them to practice sex hormone, it's better because than blocking the treatment itself, and also preventing those sport people to just inject themselves with testosterone, because they will end up with stroke and hypertension if they throw themselves, if they're giving themselves 2,000, 3,000, 5,000 testosterone. Trust me, they will end up into the ER.
This is why it's become my passion really to teach providers, and particularly my specialty is more in the menopausal world, particularly as I've gone through perimenopause now, and it's a freaking nightmare. So to be able to train providers how to responsibly and wholly manage these conditions, I don't want to say ailments necessarily, but they really are. I mean, this tissue degeneration. And if we can teach other providers at this level of having a whole understanding of how this affects our global metabolism, our global tissue integrity, rather than, again, this compartmentalized approach of like, okay, go see your cardiologist, go see your endocrinologist, your every kind of ologist, instead of this integrative, like, this is affecting all of our tissues. This is why we have these receptors on every single tissue in our body. There's a reason for that. And we have to optimize it in the appropriate physiologic ratios. And so that's why I've created the mentorship program I have. That's why it's a shameless plug a little bit, but also why I created that webinar series that's going to be available on my website if anybody's interested, to really train folks out there. I can only see 8 to 10 patients a day. I'm exhausted at the end of the day going through these lab reviews and helping patients understand their own physiology. So if we can teach more providers out there how to do this responsibly, instead of like, oh, I don't know, I went to this weekend thing and I learned to give testosterone, so we're just going to start injecting people on Monday. We're not doing a service to the patient base.
If you need CME, let me know. I can provide you the CME.
Super. I'll talk to you about it after for sure.
Okay. There's a couple of questions that one or two questions that I have here, but I need to end the CME portion of it so that we can get the answer. So do you have anything else, Dr. Nario, or anybody else?
Yeah, so this is, again, this is a curious question to knock my list off from the chat. Well, your AI protocol, when would you use that as your first line option to raise testosterone? Meaning the aromatase inhibitor protocol that you just mentioned. When would you use that as like, oh, this is the first thing I'm going to do on this patient?
Yes, I would say for somebody who's moderately impaired, right? So if this is your patient who lacks motivation, concentration, maybe getting a little chubby, the chubby hubby, but he's got a level of about 450, 500, but he's just not optimized, I think that might be a great candidate for this, because I've turned away a couple of patients who I'm like, testosterone's not the first line I would use for you. And so I've tried things like maca root and whatever, and then it's kind of BS. Like, it's not getting their levels up, maybe a little squeak, but we're really not moving the needle to where they feel that clinical benefit. But knowing what I know now, like, maybe they're a candidate to just start on a little bit of anastrozole, like 0.5, 3 times a week, or even just that 0.5 every day, or 1 milligram a day, sort of start low. see what the benefit is, get a little bit more clinical experience, have 10, 20, 30 patients who start at 0.5 3 times a week, then 0.5 once a week or once a day, and then 1 milligram once a day, and see what that sweet spot is. Then you can come back to them with, I think, a little more education to say like, okay, well, I've had like so many men use this and they get a really good benefit if you're on 1 milligram a day. And that'll help raise your testosterone levels. So I read these things and I take them with a grain of salt. I look at who paid for the study, right? And then implement it a little at a time. And I'll let patients, I'm very transparent. I'm like, hey, look, I haven't tried this, but I just read about it. It's supposed to work. You want to give it a shot? And a lot of my patients are game. They're like, sure. I mean, it's not a permanent thing. We're not, ultimately blocking off any ability to do something else later. Let's try it. Because a lot of my gentlemen as well in my practice are very well read. They're very educated. They may have had a bad experience with testosterone in the past. So they don't necessarily want to be on it. They just know they need to feel better. They're not feeling their greatest. So I think it's worth a try.
And you were checking
I think
3
before
months.
you try to doing estradiol, there's a list of supplement that are aromatase inhibitors, because aromatase they get activated with oxidative stress, by the way. And once you start doing iodine, prognolone, progesterone, and a list of supplement which I can share that inhibit aromatase, if all of those fail and still you have high estrogens, like crazy high, like we have a case that Stefan was sharing it to me. He said, Dr. Halas, I did everything. Iodine, progesterone, prognolone. I did everything. And the patient's still estrogen is very high. And the only thing that can suppress it is the estradiol, and he returned back to give some of estradiol. So I think you start with all those natural aromatase inhibitors, iodine, progesterone, and all the supplements, and then they fail. You may end up with estradiol, but you still need to look at what makes the aromatase overactive. It could be some oxidative stress that is not being taken care of, the MTHR, or that needs to be. And some of them, they're epigenetically. Genetically, they have aromatase overactive, and that needs to be screened as well.
Yeah, there'd been some case reports of that, like a certain family in Japan, I think I saw in the literature. So there were some studies of that as well, but it seems to be fairly rare to just be like a familial genetic aromatase issue specifically, but certainly it can happen. I mean, any gene that's out there, you can mutate. But I agree with you, Dr. Halasa. I think it depends on the severity of clinical symptoms and patient's ability for compliance. So while I love like a number of things out there and the IR beds and the saunas and your UV lights and the blue and the greens and the whatever colors and go work out at the gym and do your meal prepping and yes, all of those things. But when somebody's like super a clinical mess and they're like, I need to feel better tomorrow or I am going to go on antidepressants, then you may need something that's a little bit more of a direct approach in my clinical experience. Also, again, for my men, the multitasking, let me put my whole pill container together is not happening. They will literally just take whatever their wives give them. So I'm like, so is she giving you that arsenic supplement? They're like, I don't know. She just gives me stuff and I take it. Which, with respect, that's fine. But if we're making it super complicated with 14 different natural supplements, then it can be a little harder for them to comply. So we can give them one dose of anastrozole, once a day for however long, recheck those levels, get them better, and then say, okay, let's transition back to a natural supplement, something that's herbal, that's going to maybe be better metabolized. Make sure you're working on that alcohol consumption. How's your sleep apnea? Did you ever get that sleep study, right? Just to get my gentleman to do a sleep study is difficult. So, I think we've got to take that patient right in front of us. That's where I think that we don't have the necessary protocol base that I know a lot of medical groups are trying to push in those larger, Providence, Kaiser, Optum, pick one. They're all trying to make everything on a protocol so we can give it to tertiary care providers and have them just plug and chug. And it's just not that simple. I don't think it ever will be. I hope it never is.
Okay.
Dr. Bill, I got my list all crossed out. Thank you, Dr. Jackie. That was a great presentation.
Thank you.
No, thank you guys for having me.
So thank you, Dr. Jackie. Next week we have Rosemary McKenzie's returning, and she is our hormone monitor.
Mira Health.
And so she's returning for a deeper dive into how she does hormone monitoring for females. So thank you all, and